Bismillahirrahmanirrahim. Today, topic of my presentation is lymphatic filariasis. The quotation of the day is: people begin to become successful the minute they decide to be. Learning outlines of my presentation are: introduction, epidemiological triad, chain of transmission, levels of prevention, and recent advances. Learning outcomes. At the end of presentation, we'll be able to describe epidemiological triad, prevention aspects, and recent updates. Introduction. Lymphatic filariasis, commonly known as elephantiasis, impairs the lymphatic system and can lead to the abnormal enlargement of body parts, causing pain, severe disability, and social stigma. It is caused by infection with parasites classified as nematodes, roundworms of the family Filariidae that are transmitted through the bites of infected mosquitoes. It is considered globally as a neglected tropical disease. Global burden. Lymphatic filariasis affects over 120 million people in 72 countries throughout the tropics and subtropics of Asia, Africa, the Western Pacific, and parts of the Caribbean and South America. Approximately 1/3 of infected individuals have physical manifestations of elephantiasis. Physical disabilities due to elephantiasis and other chronic organ damage result in the loss of nearly 6 million disability-adjusted life years per year, as shown in the table. As you can see here, that the greatest impact is in Asia, then followed by America. And this is a geographical representation of endemic countries. That is South America, Africa, and this Asia. Now, according to WHO, 856 million people are at risk. 6.7 billion treatments delivered in the time period between 2000 to 2016. 499 million people no longer require treatment. Prevented or cured more than 97 million cases, and $100 billion averted lifetime economic loss. So lymphatic filariasis is eliminated as a public health problem in 10 countries. We will discuss it further in the end. Okay, now we come to mode of transmission. Filariasis is transmitted by the bite of infected vector mosquitoes. The parasite is deposited near the site of puncture. It passes through the punctured skin or may penetrate the skin on its own and finally reach the lymphatic system. The dynamics of transmission depends upon the man-mosquito contact, for example, infective biting rate. Now, life cycle. The infection spreads from person to person by mosquito bites. The adult worm lives in the human lymph vessels, mates, and reproduces millions of microscopic worms, also known as microfilariae. Microfilariae circulate in the person's blood and infect the mosquito when it bites a person who is infected. Microfilariae grow and develop in the mosquito. When the mosquito bites another person, the larval worms pass from the mosquito into the human skin and travel to the lymph vessels. They grow into adult worms, a process that takes 6 months or more. An adult worm lives for about 5 to 7 years. The adult worms mate and release millions of microfilariae into the blood. People with microfilariae in their blood can serve as a source of infection to others. Okay, here you can see that mosquito is taking a blood meal, the infective L3 larva entering the skin. And in humans, the adults grow in lymphatics where they mate and produce sheet microfilariae that migrate into lymph and blood channels. And then mosquito takes a blood meal, ingest microfilariae. Microfilariae shed sheets, penetrate mosquito's midgut, and migrate to thoracic muscles. Then it is converted to L1 larvae, then L3 larvae, then migrate to head and mosquitoes proboscis, and then the infective L3 larvae entering the skin of humans. Then we come to epidemiological triad. First comes host. Man is a natural host. Host factors are age. All ages are susceptible to it. In endemic areas, filarial infection has been found even in infants aged less than 6 months. Sex. In most endemic areas, the microfilarial rate is higher in men. Immunity. Man may develop resistance to infection only after many years of exposure. Migration. It has led to the extension of filariasis into the areas previously non-endemic. Social factors: urbanization, industrialization, migration of people, illiteracy, poverty, and poor sanitation. Then its agent. The causative agents of lymphatic filariasis include the mosquito-borne filarial nematodes, Bushraria bancrofti, Brugia malai, and Brugia timori. An estimated 90% of lymphatic filariasis cases are caused by Bushraria bancrofti. Vector. A wide range of mosquitoes can transmit the parasite depending on the geographic area. In Africa, the most common vector is Anopheles. In America, it is Culex cunnificatus. Aedes and Mansonia can transmit the infection in the Pacific and in Asia. Environmental factors. Climate. Climate is an important factor in the epidemiology of filariasis. It influences the breeding of mosquitoes. The maximum prevalence of Culex cunnificatus was observed when the temperature was between 22 to 30 degrees centigrade, and optimum longevity when the relative humidity was 70%. Drainage. Lymphatic filariasis is associated with bad drainage. The vectors breed profusely in polluted water. Town planning. Inadequate sewage disposal and lack of town planning have aggravated the problems of filariasis. Incubation period. This period most commonly is 8 to 16 months or may however be longer. Clinical features. The disease manifestations can be divided into two clinical types. First is lymphatic filariasis. It is caused by parasite in the lymphatic system. And the second is occult filariasis caused by immune hyperresponsiveness of the human host. Lymphatic filariasis. These are the stages of lymphatic filariasis. First is asymptomatic amicrofilariemia. In all endemic areas, a portion of population does not show microfilary or even clinical manifestations, although they have the same degree of exposure to infective larvae as those who become infected. With presently available diagnostic procedures, it is not possible to determine whether persons in this group have detectable infections or whether they are free from infection. Then asymptomatic microfilariemia. In these people, blood is positive for microfilary. They may remain without any symptoms for months, in some instances for years. They are an important source of infection in the community. These carriers are usually detected by night blood examination. Then stage of acute manifestations. In the first months and years, there are recurrent episodes of acute inflammation, lymph glands and vessels. The clinical manifestations comprise filarial fever, lymphangitis, lymphadenitis, lymphedema of the various parts of body, and of epididyma orchitis in males. Then stage of chronic obstructive lesions. The chronic stage usually develops 10 to 15 years from the onset of first acute attack. This phase is due to fibrosis and obstruction of lymphatic vessels, causing permanent structural changes. In chronic Bancroftian filariasis, the main clinical features are hydrocele, elephantiasis, and chyluria. Elephantiasis may affect the legs, scrotum, arms, penis, vulva, and breast, usually in that order of decreasing frequency. Then its second type, occult filariasis. It refers to filarial infection in which the classical clinical manifestations are not present and microfilariae are not found in the blood. It is believed to result from a hypersensitivity reaction to filarial antigens derived from microfilariae. The best known example is tropical pulmonary eosinophilia. It is distinct clinical syndrome characterized by chronic pulmonary infiltration in chest X-ray, hypereosinophilia of the peripheral blood, and respiratory symptoms like low-grade fever, cough, chest pain, and asthmatic attacks, especially at night. Then levels of prevention. In primary prevention, health promotion, specific protection, health promotion, mosquito control, clinical control by spraying DDT, malathion, effective drain and sewage system to eliminate breeding of mosquito, use of bed nets, house screens, chemotherapeutic age control. It is based on mass or selective treatment of the cases by administering diethyl carbamazepine or use of DEC medicated salt in populations exposed to filarial infections. Now, according to WHO, the best way to prevent this disease is to avoid mosquito bites. The mosquitoes that carry the microscopic worms usually bite between the hours of dusk and dawn. And if you live in area with lymphatic filariasis at night, sleep in air-conditioned room or sleep under a mosquito net. Between dusk and dawn, wear long sleeves and trousers. Use mosquito repellents on exposed skin. And another approach to prevention includes giving entire communities medicine that kills the microscopic worms and controlling mosquitoes. Annual mass treatment reduces the level of microfilariae in blood and thus diminishes transmission of infection. And this is the basis of the global program to eliminate lymphatic filariasis. Then specific protection. Currently, there is no vaccine available to prevent this infection in humans, but it is possible to develop a prophylactic vaccine against lymphatic filariasis in humans, and much work needs to be done, but it is clear that a prophylactic vaccine combined with targeted chemotherapy is critically required for eliminating lymphatic filariasis worldwide. Then diagnosis. In diagnosis, we take samples from peripheral blood, chylus, urine, exudate of lymph, varix, hydrocele, fluid, lymph node biopsy, skin specimen, and we do microscopic examination. It deals with detection of microfilariae, and it is the standard method for diagnosing active infection, that is identification of microfilariae in a blood smear by microscopic examination. The microfilariae that cause lymphatic filariasis circulate in the blood at night, called nocturnal periodicity. Blood collection should be done at night to coincide with the appearance of microfilariae, and a thick smear should be made and stained with GIMSA and HNE stain. The other methods are microscopic examination, that is detection of adult worms in lymph node biopsy. Hematologic examination, eosinophilic count is done, as you know that it is raised in occult flares. Serologic test, complement fixation test is performed. Intradermal test, immediate hypersensitivity test, flaral antigen is injected on skin. After 30 minutes, a wheal over 2 centimeter appears. Now we come to management. Lymphedema management. It is caring for the skin by washing, drying the affected limb or area, preventing and treating entry lesions, providing lymph drainage by elevating the lymph and exercising. Now, treatment for uncomplicated acute lymphangioadenitis. It is the condition in which there is infection of skin, lymph vessels, and lymph node. So its treatment is that give analgesics such as paracetamol, 1 gram given 3 to 4 times a day. Give oral antibiotics such as amoxicillin for at least 8 days. And in case of allergy to penicillin, oral erythromycin can be used. Clean the limb with antiseptic. Check for any wounds, cut, abscess, interdigital infection. Clean with antiseptic if any present. If local superficial skin infection is found, give antibiotic cream. Apply antifungal cream if interdigital infection is present. And we do not give antifilarial medicine because microfilariae are not present in the blood in this stage. Home management includes drinking plenty of water, rest, elevation of limb, wriggling the toes, cooling the limb with cold water, and washing the limb. Then management of severe ADLA. It is referring the patient to physician immediately to receive recommended antibiotic treatment, IV benzyl penicillin, and in case of penicillin allergy, we give oral erythromycin, 1 gram given 3 times a day, or other antibiotic according to local situation, and give analgesic antipyretic such as paracetamol. Do not give anti-flaral medicine. Now, treatment according to CDC, patients who are currently infected with the parasite means that their blood is positive with microfilariae. For those patients, we give diethyl carbamazepine, and see, according to CDC, it gives the physician the choice between 1 or 12 days treatment of DEC. 1 day treatment is generally as effective as 12-day regimen. DEC is generally well tolerated, but it should not be administered to patients who may have onchocerciasis, as DEC can worsen onchocercal eye diseases. And in such patients, ivermectin is the drug of choice to treat lymphatic filariasis. Now, patients with clinical symptoms, people with lymphedema and elephantiasis are unlikely to benefit from DC treatment because most people with lymphedema are not actively infected with filarial parasite. So, to prevent lymphedema from getting worse, patients should ask their physician for referral to lymphedema therapist so that they can be informed about some basic principles of care, hygiene, elevation. We have discussed all these before. And but patients with hydrocele, they should go for surgery. And there is some evidence that suggests that a course of the antibiotic doxycycline may prevent lymphedema from getting worse. Now coming to updates. WHO launched the global program to eliminate lymphatic filariasis in 2000, and this strategy has two components: to stop the spread of infection. Second is to alleviate the suffering of affected populations. And global progress towards elimination, that is neglected tropical disease roadmap target global elimination as a public health problem by 2020. According to it, China and the Republic of Korea were declared to have eliminated lymphatic filariasis as a public health problem in 2007 and 2008 respectively. Of 73 countries listed by WHO as being endemic for lymphatic filariasis, 18 countries have completed interventions and are conducting surveillance to validate elimination. An additional 22 countries had delivered mass drug administration in all endemic areas and are also on track to achieve elimination. The remaining 33 countries have not been able to achieve 100% geographical coverage. And about Pakistan, geographically, Pakistan is not surrounded by filarial endemic countries except India. Lymphatic filariasis is a major health problem in India. The situation in Pakistan, however, is very different. Because of inadequate availability of information, the actual prevalence of disease is not known. Lymphatic filariasis due to Wuchereria bancrofti and B. malgai did not exist in Pakistan prior to 1947, except for a few isolated cases. It was, however, endemic in former East Pakistan, presently that is Bangladesh. Endemic filariasis has not been reported in Pakistan. However, there is possibility of transmission through imported cases from neighboring countries such as India. And this is a research note. According to it, as you know, the filariasis is a major health problem in South Asia, particularly India, Sri Lanka, and Bangladesh. Pakistan was presumed to be not affected. And we report for the first time confirmed case of tropical pulmonary eosinophilia in indigenous patients as a result of infection with Wuchereria bancrofti. So tropical pulmonary eosinophilia due to Wuchereria bancrofti, although rare, but it is present in Pakistan. Now coming to MCQs. The most common vector for lymphatic filariasis in Africa is Anopheles right. How long can an adult filarial helminth live in its vertebrate host? Yes, 5 to 7 years. Which part of the lymphatic system does filarial nematode reside? Lymphatic vessels, lymph node, lymphatic duct, spleen. Lymph node. It's lymph node. Which life cycle stage of the filarial pathogen is infective to humans? Microfilarial L1 larva, L2, L3.
L3.
It is D, L3 larva. Where does the infective life cycle stage of a filarial pathogen develop in its arthropod vector? In thoracic muscles, abdominal muscles, in ocular muscles, in the gut. It is thoracic muscles. Right answer is thoracic muscles. The filarial larva can be ideally collected from the sample of biopsy of liver, peripheral blood at daytime, smears of spleen, peripheral blood at midnight. Right answer. The causative of filariasis is schistosome trichodenella. Yes, right. This accurately does not describe lymphatic filariasis. It is caused by parasitic worms Brugia malai and Wuchereria bancrofti. One of the most common manifestations is chyluria, chiefly affects the lower limb. Intermediate vector is the nematode. Yes, because intermediate vector is mosquito. Which of the following is not true about occult filariasis? Hypersensitivity reaction, no clinical manifestation, microfilary present in blood, infiltrates in chest X-ray. Yes, because microfilary are absent in blood in occult filariasis. The recommended regimen for treatment through mass drug administration is through single dose of dithylcarbamazepine, single dose of albendazole, single dose of dithylcarbamazepine plus albendazole, or 2 doses of ivermectin. It is single dose of dithylcarbamazepine and albendazole. C. This is the key. And these are the references of my presentation. Thank you. Any question?
छोड़ दे